course. And you see this contained hematoma. And the LV is, in our lab, we try to get any patient coming to the lab should have an echo. And increasingly with STEMI, I'm trying to get every patient, and this should not delay the procedure time. So look, there is a little bit of MR. So as soon as we start the angiogram, the patient starts deteriorating. The right is total, and then this is the left system. And patient deteriorated in the lab. And what we talked about this, that once you are in shock, quickly recognize and then salvage this as soon as possible. The number of levofed and vasopressin and whatnot. If the pressure is going up, your complications and mortality will go up. So we did a quick right heart cath, and as you notice that the PA catheter was helpful, and we see the cardiac power output, and we realized that this is primarily LV problem. So my question is, what do we do now? Any idea? Patient has this abdominal aortic aneurysm, and we did the cath. We cannot go from deployed, right radial we are using. What to do now? And patient decompensated in the lab. So again, stay calm, call the surgeon. The surgeon is not going to help you because they already threw the towel. So, and I did already one mistake taking the advice from the surgeon, squat some dye and be non-ischemic alcohol. Now we're in a mess. So what we did, we put we told the surgeon that you need to help us. So we went to the OR with the subclavian impella and then brought the patient back. And then we did the LAD. The fellow did not do well, so fellow thought that I would pick him out, but I didn't. I used a 6 and 7 French, 6 or 7 sheet, and I still let him do. He was very happy. And then the patient then subsequently had the endovascular repair, and then we gradually weaned off the impella. So in a situation like this, I try to keep it simple, and if you see that there was a bifurcation in the LAD, but if you have TIMI3 flow, then it is time to quit. And we have full collateralized flow from the RCA, and he actually did well. 75-year-old with elective TAVR, and then corner is okay, right heart wedge was 18, everything is fine. And then TAVR went well, the access is good, and everything fine. The surgeon is chit-chatting, and we are doing the implantation, all good. They went to the floor next door, and then became hypotensive, tachycardic, and they thought that this is vagal, gave atropine and fluid. And then my rule is that if it is second time hypertension, please take a note, second time hypertension, it is not vagal. So do not entertain this fellow differential, that vagal in the top. There's something else going on. Any suggestion? What to do now? Post-TAVR, hypotensive tachycardic, access side good, patient is still sweating, and yeah. This is of course Ramesh, so he will be here. So I don't know what you do. We lately are doing this. This is precondition tamponade. We are using the micropuncture needle, and then using bedside with the echo. You probably don't need the fluoroscopy, but if you have fluoroscopy, you can put a 5 French pigtail. But the micropuncture needle actually is very helpful. So she did okay. So now this is the disaster. So right coronary good. So I don't know whether I should say this. This is one of the attending, new attending, take the sir. And then actually I'm also to be blamed because I look at the LAD ostia. I said, they send me a text and say, okay, do the sir, leave the LAD ostium for me. I'll take care of it. Don't go for the LAD ostium. Cert is good, right? And then got a reasonably good result. Agree? So 24 hours later, when I'm on call, patient got worse chest pain, and I did not give you all the diagnostics. Cert stent is closed, and now the LAD ostium looking even worse. So we put an impella because I thought this is too much to do work on this ostial left main ostial LAD and then cert, and we got the good result. So interestingly, the patient is an Iranian and he has a good-looking daughter, and they were after my fellow. So I had to withdraw the fellow in the follow-up clinic. So that's kind of interesting. It's a 91-year-old female, and this is the thing that I was telling in the morning, that you need to think about whether to take patients to the cath lab. So, right, so watch. The story is, this is someone who started this gap in the cath lab. So, ST elevation on the inferior legs. When I looked at the EKG, it's not really ST elevation, it's a minimum. And troponin was really high. And the ER, emergency room, called steady. And we had to, the person on call said, oh, we'll take to the cath lab. 91 year. Okay, so this is the right. The left doesn't look that bad. So this is the balloon and stage, and then now this. So, and it is important that when this happens, first of all, you stay calm, cath lab, and then call for other. And also, I believe that if you need to have access, get the other operator to get the access from the other side. But one thing you should not do or cannot afford to do is lose the wire. So, but this is what I call the, no offense, Nagasaki situation. So and then the covered stent. I don't know routinely you keep covered stent in your lab or not, Ramesh? So that is one issue, but if you have dissected the artery, and this is a free flow perforation, in a dissection situation, if you don't have the covered stent, and I've done a couple of cases where we have this issue with the size, I have used 2 stents back to back. At that point, you don't worry about the metals, you just salvage the situation. So one stent after another on the top of the previous stent, and you cover that. So that also can happen. So and when we do the rota, we have this distal rota where perforation is the worst because you can't go there and do anything, and you just wait and pray. So, but in otherwise perforations, you should be able to handle that. First of all, stay calm, prolong balloon, and then keep the covered stent or sandwich stent and salvage. Thank you. Get the other operator, get next on the other side.
Thank you, Dr. Chowdhury H Ahsan. Brilliant cases, excellent demonstration. But we don't have the luxury of impella, using impella here. So given the situation here, how do you tackle in Bangladesh?
So let me tell you something. As we are doing the impella is a pain also. So Ramesh would agree that from the access side to the oozing, from that to the positioning, hemolysis. So it's not simple, but it does help you. I think, jokingly I say this, impella is more for the operator than for the patient sometimes. Because it keeps you smooth line. If you have cardiac output is good, hemodynamics is good, and you are doing the left main, like Fazilapa was doing the road by 6 main USD, and I was hoping that the lady and impella just hands on the corner. But it has at that point,
We also have very much to discuss on perforation, but as time is not allowing, so I'd like to congratulate you for a nice presentation. Our next presenter is Dr. Ashok.